Hello and welcome to Nolte Chapter 21, which is all about eye movements. And I took this lesson from Nolte's Chapter 21 and a lot of information with permission from Dr. Dishman's Clinical Neurosciences Institute for part of the Neurology Diplomate program is where I got a lot of this information from as well. So this really starts to pull together a lot of what we've done so far and why eye movements are so important in understanding what's going on with the brain, so diagnostics and for neuro rehab treatments. This is the outline for Chapter 21, and it includes the hyperlinks. So you can hover over it and then Control-click, and it should take you, if you have access to the book, I believe you have to buy the book, but if you have access to the book, it should take you right to that chapter if you wanted to read more about it. So we're going to go through, basically it's going to be our eye muscles and the movements and the cranial nerves and the pathways and what all of that means in terms of diagnostics and rehab. Let's start here with looking at our extraocular eye muscles. So let's go through these here. You can see superior oblique. Let's start right up here. Okay. Note this superior oblique tendon going through the trochlea here. Okay. Notoriously, superior oblique is the one that kind of trips people up when we are studying it. I have added in the eye movement website on your website here for your class page. So you can play around with that and really get an idea of what that's doing. So it's interactive and you can move it around and really see what's going on there with the superior oblique. I think that's the best way to do that. You can see superior rectus muscle. That's a little bit more straightforward. I'm going to go for a blue marker here so you can see it. So superior rectus, remember that rectus just means straight. Okay, so this is superior on the eye and it is straight. There you go. Lateral rectus, of course, would be here. It's been cut away so you can see the optic nerve in yellow back here. Okay, so the optic nerve. Inferior oblique is also a little oddball here, so he is right in there. Inferior rectus, you could see that. And the common tendinous ring here. So you can see them all on this view as well. Lateral rectus, medial rectus, which would make this area the nose here. That's a very accurate looking nose, right? And then you can see inferior oblique at a better angle right here. You can see the trochlea right here. That is part of the apparatus of holding in that superior oblique. And this is your practice page, so practice writing these out and understanding where these muscles are. So pause here, take as much time as you need, and come on back and I'll see you for the next slide. Table 21.1 in Nolte tells us the extraocular muscles contributing to movements around a different axis. So movement of adduction or look in towards your nose would be medial rectus. Other muscles contributing to this would be superior rectus and or inferior rectus. Movement of abduction would be lateral rectus is the principal. Other muscles contributing could be superior oblique and inferior oblique. Movement of elevation or looking up would be superior rectus, and then the other muscle contributing here would be inferior oblique. Depression would be inferior rectus. The other muscle contributing would be superior oblique. Movement of extorsion would be inferior oblique, and other muscle would be inferior rectus. The movement of intorsion would be superior oblique, and the other muscle would be superior rectus. The medial and lateral recti adduct and abduct the eye. This is number 2 on the list of the outlines, so we'll be numbering these throughout the PowerPoint to make it easy for you to reference back and forth to your book. The medial and lateral recti are situated in a horizontal plane, so contractions of these muscles rotate the eye around a vertical axis. This makes their actions straightforward, and you can see that in the picture there, the figure 21.4. The medial rectus adducts the eye, and the lateral rectus abducts the eye. So the midline, if the eye is turning towards the midline, that's adduction. So think of it as kind of looking in at your nose. So not the down and in like you would need to at the actual nose, but towards the midline of the face, as opposed to lateral rectus, which is going to abduct the eye or look away from the middle of your face. Both muscles pass through sleeves of connective tissue, referred to as pulleys, as they travel from the common tendinous ring toward the eye, emerging a little posterior to their insertion points on the sclera, or the white of the eye. The pulleys, in turn, have connective tissue attachments to the walls of the orbit, so the positions of the muscles are constrained within the orbit as the eyes move. As a result, adduction and abduction continue to be the principal effects of the medial and lateral recti, even if the eye starts out in an elevated or depressed position, as you can see in the picture here. The superior and inferior recti and the inferior oblique have similar pulleys. In this sense, the superior oblique is not as different from the other extraocular muscles as it seems to be. The pulleys form important parts of an elaborate mechanical suspension system that helps control rotations of the eye. Half the fibers of the recti and inferior oblique actually attach to the pulleys rather than the sclera, or that white of the eye, adjusting pulley positions as the eyes move. The superior and inferior recti and obliques have more complex actions, so they're not so straightforward as our medial and lateral rectus. And this is because if you note the picture here, the anatomical axis of the orbit is deviated about 23 degrees laterally from what we see someone's eye to be. So the result is going to be the superior rectus, superior oblique, inferior rectus, inferior oblique. Might not make that much sense when we're actually looking at the eye. So when it contracts, it's going to appear slightly different than what the wording is. So it doesn't quite match up. And that's why. So if you look at the angle of this picture of the oblique, that can start to make sense on why it doesn't always make sense right away. So each of these 4 muscles are going to have one principal action and then weaker additional actions, and we'll look at that in that chart again. However, the pulley system constrains their directions of pull, and these secondary actions come into play only in eccentric gaze. Starting from straight ahead gaze, the superior and inferior recti largely take care of elevation and depression, respectively. Similarly, superior and inferior obliques cause intorsion and extorsion. So superior intorsion, inferior extorsion. I added figure 21.8 to illustrate the point of the last slide, and I also added in table 21.1, of which we've already seen, in order to kind of help you out as you are studying that. So pause this to kind of go over what we just talked about, but in a different format here for you. Here's a drawing from the book that illustrates what's going on with the different directions of pull. So the first one, A, you can see the direction of pull with this green arrow here. So I'll kind of move it around and highlight it so you can see it, see the arrow here. So this would be the pull coming through here. And then you're going to see the axis of rotation would be this dotted green line here. So it's going to rotate around that direction of pull. Axis for pure elevation and depression would be this blue dotted line here. And the axis for pure torsion, intorsion, or extorsion would be here. Okay, so intorsion, extorsion. If we have a direction of pull as we do in B, which is coming this way, so you could see superior oblique acting to pull the eye this way, we're going to see it rotate differently. So the axis of pure torsion here, what does that do, right? So we're going to see it move. We're going to see the axis of rotation would be the green dotted line here, and the axis for that pure elevation depression on the blue. Now these are tricky. If you don't follow that, that's a-okay. It's only if this is helpful, if this is how your brain works, great. If not, I have a website that I can direct you to. I'll post it on the very next slide, and you can play around with a 3D model that's interactive. This is the eye simulator from Western University. You can pretty much search for any of the eye simulators and kind of check them out. I found this one to be extremely useful when I was first learning this. And if you note, there's muscle settings and cranial nerve settings for both the left and the right eye. And you can even do, note here, you can even do a percentage. So when you're actually on this screen, you can slide up and down. So maybe you just want half of that lateral rectus or superior rectus moving. And then you can check off the other areas here, so like cranial nerves as well. So this is was a much easier way for me to learn it than the descriptions in the book. So if that's your style of learning, please go to this website here, and it will make a whole lot more sense for some of you by using this. I like this picture just to give another perspective of the axis of the orbit, and the axis of the eyeball here is this right here. So this is the axis of the orbit. This is the axis of the eyeball in blue right there. So intorsion of the eyeball occurs through the superior rectus because contraction of this muscle is at an angle to the axis of the eyeball. So this one right here, I think if you look at it, it's going to explain a lot between why these movements seem a little bit confusing with the different eye muscles. And then inferior oblique to the right here, you could see when it moves this way, we're going to get extorsion this way. So a rotation from medial to lateral. The same neural machinery comes into play whenever these brief, rapid movements are called for. To move our eyes voluntarily in any given direction, to glance over at something in the periphery, and in the fast phase of nystagmus. We use multiple kinds of smooth, slower eye movements to keep an image on the fovea, corresponding to the fact that an image can move on the retina if we move or if the object moves. The VOR, or the vestibular ocular reflex, compensates for head movements, supplemented in this function by OPK movements for large head movements. These smooth eye movements become the slow phase of nystagmus. Smooth pursuit movements are used to track a visual stimulus that is itself moving. Without special training, we are unable to move our eyes smoothly unless an image starts to leave the fovea. So let's go ahead and break down all of these concepts here. Let's go ahead and just define some of these terms on the next slide. These are two separate pictures. So the picture to the right, 14-32, is from your Nolte book, and the Nolte book has a different perspective. So you can see here where we are, we could see superior colliculus here, inferior colliculus here. Okay. These are the cerebellar peduncles. So the cerebellum has been cut away. So that would make this the fourth ventricle, the rhomboid fossa. So we would see medulla about here, pons area behind or in front of the cerebellum here, but behind it in this picture here. And then our midbrain, tectum area. Okay, so you can see, let me erase some of this here so you can see the rest of it. So this MLF in green over here that you see, just kind of note where that is in the midline, kind of going between that right and left superior and inferior colliculi. So we're going to look over to the left here because it has a little bit of a clearer picture of it, I think. So let's start right here with the right eye. Okay, so for right medial rectus here, we could see the innervation is cranial nerve 3. We could see the ocular motor nucleus here. And then we can see the left lateral rectus over here. Okay, so this muscle, and the innervation being cranial nerve 6 or abducens nerve. So we see the abducens nucleus here. Now remember, our nuclei are just where the cell bodies are. Okay, so ganglia in the peripheral nervous system and nuclei in the central nervous system. Okay, so what yokes these two together, as they say, is the MLF, medial longitudinal fasciculus. This is loaded with white matter. Okay, so this is heavily myelinated and can be of common issue with our multiple sclerosis patients. So we'll see deficits in this area. And then we'll see balance issues. But we'll get to that part of the story in a little bit here. So I'm going to use my blue marker here. This is the midline of the, well, there you go, midline of the brain here. So the MLF crosses over the midline. Okay, and this is bilateral. So we're going to see the same thing over here, right? So the ocular motor nerve, ocular motor nucleus will have another MLF, which is crossing over the midline, and another abducens nucleus, remember. So we just see it on the one side for clarity's sake here, so we don't get too confused by these pictures. But just know that this is bilateral. So then we can see what's happening here is the right horizontal canal in the ear. Okay? And then the head is rotating. And we could see this here, okay, as the vestibular nuclei and vestibular ganglion. So the eye movements and the vestibular system for balance. So when I do neuro rehab or teach a yoga class, which I do neuro rehab in my yoga classes, I think it's important to do that. When we are doing our balance poses, I add in vestibular ocular reflexes. So we do a balance pose, and we hold our focus on our balance point, or our drishti, as we say in yoga, our focal point. So we hold our focus on something, and we're in a balance pose, so maybe a tree pose or standing on one leg if you're not familiar with that. And then we move our head around while we're keeping our eyes fixed on one point. And so this excites this reflex here and helps us with our balance, helps us with all sorts of interesting things, mental processing, all sorts of fun neuro rehab that we can do just by fixing the gaze and moving the head and balancing at the same time. And then we kind of play around with this with movements and cross crawls and kind of mix it all up. But this is the vestibular ocular reflex, kind of a tongue twister. That's why we just say the VOR, right? So this is the VOR. So it's rapidly adjusting eye movements to head movements so that the gaze can remain fixed on an object even though the head is moving. So our MS patients will tell you about symptoms on which they were maybe walking on a treadmill. I had an experience with a patient with that, walking on a treadmill, and she would turn her head to look at something and boom, fall off the treadmill. So the VOR needed to be exercised in this patient in order to facilitate healing. Interesting to note here about the VOR. So irrigating the ear canal with cold water in a normal individual evokes nystagmus that beats towards the opposite side. So afferent fibers are conveyed in the vestibulocochlear nerve, efferent fibers in the ocular motor nerve. So when the VOR reflex is absent in a comatose patient, it is considered a poor sign because this reflex is the most reliable clinical test of brainstem function. So why are there cows there, right? So cold, opposite, warm, same. So they put cold water, it's going to beat opposite. And then warm water, it's going to beat towards the same side. Let's spend a little time looking at the ocular motor nerve here. So that cranial nerve 3. We can see ocular motor nerve. What's it doing? The GSE aspect of it, the general somatoefferent, is all of our eye muscles except for lateral rectus and superior oblique. Lateral rectus is 6, superior oblique is 4, remember? So SO4, LR6, AO3. And then our GVE, general visceral efferent, it's going to control the pupil. So dilation or constriction of the pupil controlled by cranial nerve 3. Let's look at its course here. So to orient, obviously, our eye is up here, cerebellum is back here, cerebral aqueduct right here, superior colliculus, inferior colliculus, and then we look in front of this area here and we'll find the ocular motor nucleus here, and then the nerve coming along. Okay. Innervating the eye muscles. In yellow here we can see Edinger-Westphal nucleus. Okay. Also a part of association with that cranial nerve 3. And that's for the pupil. Okay? So pupillary constriction. You could see it up here, Edinger-Westphal. Okay. Ocular motor. You can see periaqueductal gray up here, PAG. And then the cerebral aqueduct, you can see this hole. All right, where we are. See where we are? See down here? Good. And make it a little easier to see, artist rendition. There's that cerebral aqueduct. Right in the middle there. And then that periaqueductal gray. A little bit easier to see here. You could see the ocular motor nuclei here. And then we would see our Edinger-Westphal here. He's not labeled, but that's him. Oh, what else do we see? Substantia nigra. We know that has to do with dopamine production, and we know it's pale with Parkinson's disease. Crus cerebri right here, also known as cerebral peduncles. And who could miss the red nucleus here? Check out the path of the ocular motor nerve. Okay, so this ocular motor nerve pathway here. Let's erase a bunch of this stuff here so you could see it. This ocular motor path is extremely important to note that it's going through that red nucleus. So when we see a Benedict stroke that has affected the red nucleus, we're going to see cranial nerve 3 deficits as well, which is going to be one of the salient features that distinguishes it from a Weber stroke, which affects the cranial nerve 3 as well, is a Benedict stroke is going to have weird arm movement, okay? Non-volitional weird arm movements associated with it, where Weber stroke is going to have paralysis of the arm. So red nucleus of note. Here's our cavernous sinus. So we have cranial nerve 3, 4, and then we have V1 and V2, and cranial nerve 6 over here. Okay, so 6, look all the way in there, yep. And then the internal carotid artery. And this space here is our cavernous sinus. So this is of note if there is some sort of aneurysm or dilation of the internal carotid, we might see issues with any of these cranial nerves. So maybe cranial nerve 6, maybe cranial nerve 3, and then later cranial nerve 5, trigeminal. So the V1 division and V2 division of trigeminal. Just to give you a little perspective on where that is, so we can see that cavernous sinus down here that I just showed you. Okay, so cranial nerve 3, parasympathetics in blue, somato in red, those fibers there. Cranial nerve 4, V1, V2, internal carotid. Okay, little slice here through the cavernous sinus. Here's 6 right next to internal carotid. Okay, so you're going to see that get hit first usually. And you can see up here there is our cerebral aqueduct. It's a common landmark for us to kind of see where we are in space. We could see substantia nigra here. You could see cranial nerve 4 wrapping around coming from the posterior. It's the only one that does, remember. And then you could see cranial nerve 3 coming through. Okay. And this slice right through here, cavernous sinus, is what we're looking at here. This is to help you practice. Okay, so 3, 4, V1, V2, 6, internal carotid. That's the cavernous sinus. Couple cool pictures here for you to get a little perspective. So you could see the arrows that were placed on here, and you could see this right here. They're trying to show us that that would be an aneurysm at that internal carotid and would cause all sorts of issues at that cavernous sinus. So that's pretty big. We're going to see deficits at 3, 4, V1, V2, 6. So 6 would come first. It's right next to the internal carotid, but we're just going to see all of that kind of obliterated with this one. Drawing the cavernous sinus is really the best way to learn this. Okay, so just kind of draw it over and over again. But the nice way to kind of get some perspective here, we could see it in a couple of different spots here. Cavernous sinus this way, cavernous sinus over here, over here. We could see the pituitary gland here. So what if there was a pituitary tumor? That might affect that area as well. So cranial nerve 3 coming along. We see the superior branch go off to levator palpebra superioris, superior rectus, this inferior branch coming down to inferior rectus muscle, medial rectus muscle, and the ciliary ganglion, and the inferior oblique. Cranial nerve 3 lesions can lead to deviation of the eyeball down and out. So we could see this eyeball here, down and out. Pupillary dilation and complete ptosis or drooping of the eyelids. Let's take a look at the trochlear nerve now. It supplies the superior oblique muscle. So remember SO4, LR6, although there's 3, this is the SO4. The nucleus lies in the midbrain at the level of inferior colliculus near the ventral periaqueductal gray. It's the only cranial nerve to exit the brain posteriorly, and it has the longest intracranial course, not the longest nerve, longest intracranial course, because it's doing this posterior exit here. So you can see my red marker down here coming along. And then out to SO4, just a tiny thin nerve here. Here's the periaqueductal gray, and that is around the aqueduct in the center here. I'll erase that. There we go. So we can see here the medulla area here, up to the pons, into midbrain area. This is the internal capsule up here, this kind of punk rock hairdo on the thalamus. And so what we can see here is ocular motor nerve coming out. Look over to the left-hand side here. We can see internal capsule, thalamus, pineal gland is this right here. This is the superior colliculi, inferior colliculi, and then there's our trochlear nerve coming from the back area here, wrapping around to the front. And here's a nice picture, I think, of the superior oblique and the trochlear nerve. So note the yellow nerve coming here, innervating this little muscle here, superior oblique, with this little pulley here, and attaching to the eyeball underneath here. When we test for superior oblique, we have them look at their nose. Okay, so we do the cardinal fields of gaze, follow my finger in this H-shaped pattern, and then out to the sides as well. And when they look down at their nose, we're checking to see how the superior oblique is working. Superior oblique is notoriously tricky. I always suggest to go look at the eye movement simulator in order to really get it, because when we talk about it, it notoriously brings up questions, and different resources say that it's doing different things and it doesn't make much sense. This is one of my favorite pictures to kind of explain that. So we'll read it here. Superior oblique. So to simulate the action of the superior oblique, you can pretend that your head is a large eyeball. Throw an arm up and wrap it around the back of your head. Your elbow becomes the trochlear pulley. If you pull your arm, your whole head should twist. The direction of the head movement, either up, down, or rotational, will depend upon which direction you're looking when you started pulling. The same action occurs in the eyeball, such that your patient will see vertical diplopia when looking medially towards the nose, such as when we read a book, and we'll see more rotational doubling when looking to the side. So let's look at the cranial nerve palsies here and what we would see on exam. So a right, let's get my marker here, right third cranial nerve palsy here, what we're going to see on exam. So we're going to see this deviation of gaze. We're going to have a smaller angle of horizontal squint. So see the squint in the eye here on this eye. And then right eye turns downward and outward, down and out, remember. And then what happens if they look away from the affected eye, unable to adduct the right eye, larger angle of squint, and double vision further apart. So let's look, for example, if they have a right fourth nerve palsy. No obvious squint, so no diplopia look. Right eye turns upwards. Right eye elevates more as it moves medially, and we see double vision further apart. Right sixth nerve palsy, we'll see unable to abduct, so LR6, remember? So unable to abduct the right eye, larger. Angle of squint, double vision further apart. Right eye would then turn inward, and then unable to adduct the right eye, no obvious squint. Let's look now at abducens nerve, or LR6, lateral rectus, innervated by cranial nerve 6. Cranial nerve 6 is abducens. The nucleus lies in the floor of the fourth ventricle within the caudal pons, caudal being towards the tail, remember. Axons pass ventrally through the pons without decussating, so it's in the front area of the pons and it doesn't cross over. The course is going to be the brainstem, anterior to the pons, pierces the dura overlying the basilar portion of the occipital bone, runs up to the petrous portion of the temporal bone from its apex, and then we see it in the lateral wall of the cavernous sinus. And here is our picture to illustrate that. So we can see cerebellum back here. Fourth ventricle would be right here. And then we can see a picture of this area right here. So cranial nerve 6 abducens fibers we can see right in here. And then the abducens nucleus is nice and labeled here for us. And then we can see it coming down, exiting at the pontomedullary junction, so where the pons and the medulla meet. And then the course that we take all the way up, ending at that lateral rectus. And then we can see here a picture of the nerve as it gets to that lateral rectus. Let's take an in-depth look at the medial longitudinal fasciculus, or the MLF. The paper cited at the bottom explains that the MLF and its constituent pathways is extremely important to understanding a number of important principles in neuro-ophthalmology. And I would add on that pretty much any neuro information. So the eyes are the windows to the soul. In neurology, we say the eyes are the windows to the brain, and the MLF plays a huge role in this. The article states the MLF is an important structure and it's composed of numerous projection systems involved in the regulation of eye movements. Pathology at this location can produce a constellation of abnormalities, many of which can be identified upon careful bedside neurological examination. The MLF is organized as a pair of white matter fiber tracts that extend through the brainstem and lie near that midline just ventral to the fourth ventricle in the medulla and the pons, and the cerebral aqueduct in the midbrain. The MLF contains fibers that ascend and some that descend within the brainstem tegmentum and interact with oculomotor control circuitries involved in the coordination of horizontal, vertical, and torsional eye movements. So it goes up, it goes down, and it's coordinating our eye movements for us. The MLF is a central conduit for many brainstem pathways and is the final common pathway for all classes of conjugate eye movements, including saccades, which are the rapid refixations, smooth pursuits, and the VOR, or the vestibulo-ocular reflex, including semicircular and otolith-mediated ocular motor reflexes. The 6 ocular motor nuclei, or pairs of cranial nerves 3, 4, and 6, are interconnected via the MLF, which transmits vital information for the purpose of coordinated and synchronized movements of the eyes to a visual target. Within this system are both excitatory as well as reciprocal inhibitory projections that serve to precisely regulate the interplay between agonist and antagonistic muscles of the eyes. So basically, the MLF coordinates our eye movements and allows for this smooth movement of our eyes, whether it's fast or slow, and it's going to allow the eyes to move equally with each other. This picture is taken from the theme book at page 350. Let's go ahead and point some of the basics out to kind of orient yourself here. So hypothalamus region is right here. So this would be the front, this would be the back. Cerebellum is over here. Medulla is here. We can see the pons right here. And then the midbrain is right above that. I'll go for yellow here. Okay, so midbrain is here. Looking to the right here in the midbrain, you could see superior and inferior colliculi here, and the cerebral aqueduct. So I'm going to go ahead and erase some of this so it doesn't look too cluttered now that we have our bearings about us. Great. Let's go ahead and look at this medial longitudinal fasciculus. Okay, so to do so, we want to follow this line right here. That's the medial longitudinal fasciculus. It ascends and descends, remember. Now let's look here, nucleus of the ocular motor nerve. I'm going to go for green. Okay, so nucleus of the ocular motor nerve, we know that that's going to be anterior to the cerebral aqueduct at the level of that superior colliculus. And then let's look at the nucleus of the trochlear nerve right here. It's going to yoke these together. Let's look down here, nucleus of the abducens nerve right here. Lots of other things on here, but I just want to point out that MLF. Okay, so this pathway here, I'm going to erase it again so you can see it. That thin strip of white myelinated fibers here that is interconnecting the nuclei that control eye movements. And then it goes beyond it as well. Okay, so it goes above and below it. The MLF is a functionally mixed pathway. It contains both ascending and descending fibers and interconnects the motor nuclei for control of eye movement, so 3, 4, and 6, and also the head, so cranial nerve 11, and the anterior horn for C1 through C4, and vestibular nuclei for smooth pursuit eye movements, but also motor nuclei of cranial nerves involved with the voluntary motor control for chewing, swallowing, and sucking. The motor nuclei of cranial nerves are interconnected via both fasciculi, so the medial longitudinal fasciculus. The pathway crosses at multiple levels, so it coordinates more than just eye movements. It's its main thing that we focus on, but it's coordinating a lot of things here. So when we see deficits at the MLF or demyelination due to MS, things like that, we're going to see a myriad of issues. Number 5, fast ballistic eye movements get images onto the fovea. So the fovea is our sharpest vision. So we want this fast, quick, kind of ballistic, kind of erratic looking, right? So saccades in the fast phases of nystagmus are extremely rapid, and they reach velocities of 700 degrees per second. This is too fast for the visual system to provide useful feedback under most circumstances. And fast eye movements generally behave as though the central nervous system computes the size of the required movement in advance, which takes about 200 milliseconds. It initiates the movement and makes no corrections during the course. These pre-programmed movements are called ballistic. So one of the few ways in which saccades are altered once they begin is through the superimposition of the VOR, or that vestibular ocular reflex, which is when we are moving and trying to keep our eyes fixed on an object. So this compensates for our head movements during a saccade. Number 6 on our outline. Motor programs for saccades are located in the pons and midbrain. Moving an eye at 700 degrees per second to a target requires a brief, strong contraction of one or more extraocular muscles, followed by a weaker, sustained contraction to keep the eye in its new position. Kind of amazing, 700 degrees per second there. This is accomplished by CPGs, or central pattern generators, whose circuitry resides in the brainstem. Appropriate patterns of excitation are provided to motor neurons in the abducens, trochlear, or ocular motor nuclei by specialized areas of the pontine and mesencephalic reticular formation. The neural machinery for generating rapid horizontal movements is located in the medial reticular formation of the pons, near the abducens nucleus, a region commonly referred to by the logical but cumbersome name paramedian pontine reticular formation, or the PPRF. And we'll see this PPRF in our lab video as well. Signals from this region project to the abducens nucleus and the nucleus of the MLF, or the medial longitudinal fasciculus, which is outlined in our lab, for connection to the contralateral cranial nerve 3 lower motor neurons in the medial rectus, with each PPRF directing movements to the ipsilateral, or the same side. A little bit simpler here for you. So the PPRF is a region of the pontine reticular formation near the abducens nucleus, containing the neurons that generate the timing signals for fast horizontal eye movements, or saccades, to the same side. The machinery for rapid vertical movements is located in the reticular formation, just dorsal medial to the red nucleus at the midbrain diencephalon junction. So in a region called the rostral interstitial nucleus of the medial longitudinal fasciculus, or what we call the RI-MLF. The RI-MLF on each side has a peculiar pattern of connections. It projects bilaterally to the motor neurons for all of the elevator muscles of both eyes, and to the motor neurons for the ipsilateral inferior rectus and contralateral superior oblique. Hence, unilateral damage here causes little or no deficit of upward gaze because the other side can compensate. But there is some weakness of downward gaze because one depressor of each eye cannot be activated. However, some of the connections required for upward saccades apparently involved more dorsal parts of the midbrain as well, because one of the common early effects of pineal tumors, so tumors of the pineal gland, is selective paralysis of upward gaze, so together with disturbances of convergence. So let's take a look and kind of break this down. So the next slide has a picture here for us to follow. I found this in the Journal of Neurology, September 2014 article here. The citation is at the bottom of the page there if you want to read the article. It's called Central Ocular Motor Disorders, including Gaze Palsy and Nystagmus. So it really does a great job of showing us the structures on the left-hand side there. And then on the right-hand side, we can see the associated issues or problems, deficits that we'll see if there's a problem in these areas. So let's look at a couple of things here. I'm just going to color code them for you here. So the posterior commissure, abbreviated CP instead, so commissure posterior. So that's going to be this area right here. And then we're going to see CP lesions, convergence, retraction, nystagmus. Interstitial nucleus of Cajal, or Cajal, either way is fine by me. This guy right here. And then a lesion here is going to lead to vertical gaze deviation, nystagmus. Next one up in green here, NPH, or nucleus prepositus hypoglossi. You can see why we abbreviate these. They're a mouthful, right? That's this guy right here. And if we see a lesion here, we're going to see horizontal gaze deviation, nystagmus. Here is the PPRF that we have mentioned. So the paramedian pontine reticular formation, and it's going to lead to Horizontal saccadic paresis, and it is this big guy right here in the middle, PPRF. RI, MLF, rostral interstitial nucleus of the medial longitudinal fasciculus. This guy up here, I should use a different color because it's right next to the other blue guy. I'll go yellow. There we go, RIMLF. And up here, RIMLF lesions, we're going to see vertical saccadic paresis. MLF, vertical conjugate gaze, remember. Cranial nerve 3, I'm going to go for green here, so cranial nerve 3. So we could see the nerve here, and the nucleus is here. So just to orient you here, this is superior colliculus, this is inferior colliculus, and then this is going to be the aqueduct, and then this would be the fourth ventricle. Okay. Medulla, pons, midbrain area. So nucleus of the trochlear nerve is up next, and he's just right down here in red on the screen here. So nucleus of trochlear nerve. And let's look over here on the right. So that MLF lesion would cause INO, internuclear ophthalmoplegia, and we'll look at that in a minute on what that means. We've talked about it before, but we're bringing it all together in this chapter here. What else do they have here? We've got bilateral floccular lesion or pontomedular lesion. We're going to see a downbeat nystagmus. And then here, if we see medullary or pontomesencephalic, so pons, midbrain, or medulla lesion, right? So it's kind of a lot of stuff. We might see an upbeat nystagmus here. So what does it say at the bottom here? The supranuclear centers for control of eye movements. These centers allow exact topographical determination of lesions in the region of the interstitial nucleus of Cajal, lead to vertical gaze holding defect. Lesions in the region of the rostral interstitial nucleus of the medial longitudinal fasciculus leads to impairments as well. So here, we're not going to memorize all of these things. We don't have to memorize all of these things to do the work that we do and do it well. But the idea that there is a rhyme and a reason, that there is a chart that you can look at when you see a patient with any of these issues. And then if you specialize in this and you do this all the time, eventually you might have it memorized, but there's really no need for that. So for me, for the boards, for general purposes, make sure that you understand PPRF, and then MLF, and then of course you're going to remember your 3, 4, and 6 and what those do as well. Number 7, the frontal eye field and superior colliculus trigger saccades to the contralateral side. Saccades are the eye movements we routinely use to explore the world visually during activities as varied as filling a tea kettle, scanning scenes and pictures, and reading. Cortical control of saccades parallels that of other voluntary movements, with an equivalent of primary motor cortex contributions from other cortical areas and interactions with the basal nuclei and cerebellum. Figure 2112 illustrates the point this way. Using saccades to scan visual scenes. A photograph called Girl from Volga, which a subject was asked to look at for 2 minutes. Recordings of the eye position during this 2-minute period were taken. Thin lines represent saccades between points of fixation, which center around parts of the face of greatest visual interest. The subject has no conscious sensation of making these saccades or of having brief periods of blurred vision. Rather, the central nervous system ignores input during the saccades and combines the visual inputs during the periods of fixation into a single unified visual perception. The frontal eye field is located just in front of the representation of the face in the precentral gyrus, in the posterior portion of the middle frontal gyrus, and the banks of the precentral sulcus. Let's unpack those words a little bit here. Frontal eye field, FEF, that's Brodmann's 8, right? Located just in front of the representation of the face in the precentral gyrus. Precentral, that's motor, so this is motor homunculus. In the posterior portion of the middle frontal gyrus, and in the banks of the precentral sulcus. It is prominently involved in the initiation of saccades. Stimulation here causes horizontal or oblique conjugate movements to the contralateral side. So horizontal or oblique, okay? So side to side or diagonal movements to the opposite side. It's mediated in part by direct projections to the PPRF and in part by projections to superior colliculus, which in turn projects to the PPRF. So either PPRF directly or superior colliculus first. Part of the supplementary motor area, the supplementary eye field, and part of the parietal lobe, or the parietal eye field, also participates in the initiation of saccades. Just as in the case of outputs from motor-related areas to the spinal cord, they do so through both connections with the frontal eye fields and direct projections to the brainstem. Stimulation of these areas also elicits saccades. And as in the case of other voluntary movements, it is assumed that each of these cortical areas has a distinctive role. The parietal eye field may be especially involved in more automatic saccades to things that appear in the periphery, and the supplementary eye field may be more involved in sequences of multiple saccades. So this makes sense, right? So automatic saccades to things that appear in the periphery, that's going to be mediated by the superior colliculus. That's part of its function, is to kind of, you see something out of the corner of your eye and you quick turn and look at it. Right? Damage to the frontal eye field of one hemisphere causes the inability to look voluntarily to the contralateral side. It can easily be shown, however, that the appropriate muscles are not paralyzed because other movements, such as those of the VOR, remain intact. Now this is where I do some neuro rehab, is I have them do the VOR. So I'll have them stay fixated on a point and move their head around to facilitate strengthening those connections. Vertical eye movements are not impaired after a unilateral lesion, and even the deficit in horizontal movements is only temporary, with recovery usually occurring in a matter of days. The relative roles of increased activity of the superior colliculus, other cortical areas, and the contralateral frontal eye field in this recovery of function are unclear. However, combined damage to the frontal eye fields and superior colliculi cause severe and long-lasting deficit in the ability to generate saccades. So what are saccades? Saccades are rapid eye movements that redirect gaze to an object of interest and result in projection of that object onto the fovea, that sharpest point of vision. Saccades result in cortical and subcortical input to that PPRF. We see the cortical areas are the frontal eye field, or Brodmann's 8. Reflexive saccades or prosaccades are visually guided in response to external cues. Superior colliculus provides the main input. So remember, superior colliculus is going to be the mastermind behind the visual reflex as well. Most superficial layer receives visual input from the retina via the lateral geniculate nucleus of the thalamus. Deeper layers have motor neurons that project to the PPRF and initiate the saccades. Sensory and motor are directly linked via synaptic contact, and then volitional or intentional saccades, volitional just means voluntary, or intentional saccades are independent of visual stimulus. So it requires higher order processing, like spatial memory and analysis of contextual cues. So let's take a look at this picture here. So we could start at a couple of spots here, but we're going to start looking right here at the frontal eye fields, Brodmann's 8, up in the brain here. Let's look at these connections. Okay, so we see connections coming into the PPRF And then we also see superior colliculus connections and then into PPRF. And then we can see cranial nerve 6 and that left lateral rectus, the MLF, crossing over and yoking cranial nerve 3, just like we did in the other picture. Okay, so let's look here. So we see the left visual field, okay, and the lateral geniculate nucleus of the thalamus, okay, crosses over to the right. So remember, we have our eyes, and then we've got the crossing over that optic chiasm, okay, and that nasal part is going to cross over, and the temporal part is going to go same side. So remember that diagram. We have our primary visual cortex. On the right, we see visual association cortex, frontal eye fields. Okay. And then we see superior colliculus getting involved, and then our reflexive saccades, PPRF, and then gaze to the left. So it's basically what's happening right here. Okay. Superior, where are we at? Frontal eye fields, volitional saccades. Okay. There are 3 types of volitional saccades: anti-saccades, memory saccades, and predictive saccades. Anti-saccades involves making a decision to avert the eyes and requires simultaneous inhibition of the reflexive saccade that would direct the eyes to the stimulus. So what we do in clinical practice, we're examining or part of rehab. We use it for both ways. So you have your hands outstretched and you're wiggling your hand saying, okay, look at my hand. And then you switch it to the other hand. So the left hand is wiggling, you want them to look at the left hand. And then you stop and then you start wiggling the right hand and you want them to look at the right hand. That's a reflexive saccade. Anti-saccade would be you're wiggling your right hand and you say, now look at the hand that isn't wiggling. And then you keep switching it up on them back and forth. So they have to look away from what they would reflexively look at. Memory saccades can voluntarily direct gaze to where an object or a visual cue had been. So it depends on an intact working memory, spatial orientation. It's memory, basically. And then predictive saccade sounds just the same as what it is, just like memory saccade. You remember where something was. Predictive, you're going to predict. So the eye is directed to where the target is expected to be. Number 8, slow guided eye movements keep images on the fovea. Fovea is our sharpest point of vision, remember? And we call these smooth pursuits. The eye movements used to keep images from moving off the fovea are slower than saccades, typically to only about 100 degrees per second, slow enough to utilize continuous feedback from the vestibular and visual systems to regulate their speed and duration. So as noted earlier, images move on the retina if you or some part of the outside world moves. These things often happen simultaneously. Think playing any sport that involves a ball, and we have smoothly integrated mechanisms all funneling through the vestibular nuclei in order to deal with both. For this slide, if you have another person around, it would be good to maybe ask them if you can observe them and ask them to do this project here with you. So smooth eye muscles usually require either a vestibular stimulus or a target moving across the retina. It generally comes as a surprise that with the head stationary, we cannot voluntarily move our eyes smoothly unless we're tracking a slow-moving object. This is easily demonstrated. Watch someone's eyes as they try to move them slowly and smoothly while there's nothing to track. Or concentrate on your own while you're doing the same thing if you don't have anybody else, and you'll kind of feel it. In either case, the result will be the same, a series of rapid, jerky movements or saccades. Some individuals can learn to have voluntary control of smooth tracking movements, but under normal circumstances and for most people, this is impossible. Interestingly, real moving stimuli and other sensory modalities provide to varying degrees an adequate stimulus for some smooth movements. For example, many people can use smooth eye movements to track their own index fingers moving back and forth in the dark, even though they're unable to see. Okay, so unable to use such eye movements to track imaginary moving fingers. Similarly, smooth muscle or smooth eye movements can be used to track a moving sound source in the dark, although less successfully than when using a somatosensory stimulus. Kind of an interesting project that you can do here. Gaze is the coordinated synergist movement of both eyes to a target. It directs the projection of a target onto the area of highest visual acuity, or what we call the fovea. It's coordinated by centers in the cortex and the brainstem, which project to motor neurons of cranial nerves 3, 4, and 6, which control our extraocular muscles. Remember, SO4, LR6, all others 3. Our horizontal gaze center is the PPRF, and lesions in the pons lead to deficits in horizontal gaze due to damage here. Vertical gaze center, the midbrain reticular formation, pretectal area, lesions of midbrain can lead to deficits in vertical gaze due to damage in these structures. And we can see this picture here that we've gone through a bunch of times. So the idea is repetition here, right? So horizontal gaze center gives input into the abducens nucleus to direct gaze to the ipsilateral side, so to the same side. Number 2, one subset of neurons projects directly to the ipsilateral lateral rectus. So we have our lateral rectus here, so cranial nerve 6. Abducens nucleus here. We can see our horizontal gaze center right here, located in that PPRF. We're also going to see here another subset of neurons in the abducens nucleus crosses the midline and travels in the MLF, so this medial longitudinal fasciculus, all the way up here, okay, to the contralateral ocular motor nucleus for cranial nerve 3. Then we see cranial nerve 3 going to medial rectus, and it's moving the eye right in towards, this is the midline right here, this dotted line. So adduction here, and ab with a B as in boy, duction there. So both eyes move in the same direction. Let's look at smooth pursuits. So instead of that quick action of a saccade, the smooth pursuit is used when tracking a slow-moving object. Again, the aim is to keep that object on the fovea, or that sharpest point of vision. So looking here, we can see our eyes. We have our cranial nerve 3 and our cranial nerve 6 innervating here, the lateral or the medial rectus here, lateral rectus here. So cranial nerve 3 coming in, nucleus here, cranial nerve 6 coming in, nucleus here. Who joins them? What myelinated tract joins, yokes these together? It's the MLF, medial longitudinal fasciculus. It crosses over the midline. We can see the vestibular nuclei synapsing with both here, coming from that cranial nerve 6's nuclei. And then we can see this vestibular nuclei. Remember, nuclei are just where the cell bodies are, right? And then we see these paths of axons. And then this is going to synapse at the cerebellum, pons, pontine nuclei, and then up to that visual association cortex, so back in this occipital lobe region. And then we see frontal eye fields as well involved, so FEFs, or our Brodmann's 8. Vestibular ocular reflex, we see the same thing happening here, MLF, abducens, ocular motor connections, vestibular nuclei here, and then look here, it's the right horizontal canal getting involved, so when we do our eye movements. So keeping our eyes fixed on a focal point or a drishti, and then moving our head around for creating eye movement that way. Even though the eyes are staying fixed on the target, those muscles are still firing off because your neck muscles are moving. In the previous slide, we saw the right horizontal canal. So let's take a deeper look into these canals. Table 21-2 in Nolte tells us the effects of increased activity of individual semicircular canals on the extraocular muscles. So what is the relationship between these canals and the eye muscles? So if you look to the left, you can see the canals, anterior, posterior, and horizontal. You might see horizontal called lateral sometimes. And then look to the excitation, inhibition for the same side. So if it's the right canal, it's the right eye that this is talking about, ipsilateral. Okay, so excitation would be contralateral. So like the right horizontal canal, the left eye. Okay, so anterior excitation would be superior rectus. Inhibition would be inferior rectus, both on the same side. Opposite side, anterior canal is going to get excited by the movement of inferior oblique on the opposite side, and it's going to get inhibited by superior oblique on the opposite side. So, for example, with that, the right anterior canal and the left superior oblique. So those are that contralateral relationship, and that would be inhibition. So the effect of increased activity on that semicircular canal. So increased activity on the anterior canal inhibits that muscle, superior oblique. Next up, posterior. So increased activity at the right posterior canal, we're going to see excitation of the right superior oblique. Inhibition of the right inferior oblique. Right posterior canal, we're going to see excitation of the left inferior rectus. And then right posterior canal increased activity would inhibit the opposite eye. So if it's right posterior ear, it would be the left eye superior rectus. That's how we read this chart. Okay, so horizontal, ipsilateral medial rectus is excited. Lateral rectus would be inhibited. Opposite lateral rectus excited, opposite medial rectus inhibited. Let's back it up and go through our ear anatomy and physiology again real quick here. So the ear has three major areas. External, or the outer ear, that's for hearing only. Middle ear, or that tympanic cavity. Tympanic, think eardrum. This is for hearing only. Internal ear is going to be for hearing and equilibrium. Receptors for hearing and balance respond to separate stimuli and are activated independently. Here we can see those semicircular canals we were just talking about. So let me highlight here in red. Right here, semicircular ducts in the semicircular canals. So we can see our anterior. I'll grab green for our posterior here, ducking behind that guy and along through here. I don't know if you can see where I'm at. And then I will do yellow for our lateral canal right here. I'm going to go ahead and erase that so you can see it for yourself without my drawing in there. And then note, there are other things that we're about to cover. So the crista ampullaris, we're going to look at this right in here, this little purple, kind of looks like a dumbbell right here. We're going to look at the utricle and the saccule and what those are doing. So utricle, saccule. We can see the nerves over here, so a little bit of facial nerve getting involved over here. We can see vestibular nerve, this big guy right here, going to all of this apparatus here. inferior vestibular ganglion, superior vestibular ganglion, or where the cell bodies are for this nerve, cochlear nerve going to the cochlea. This is for hearing. We can see the macula, spiral organ, cochlear duct, round window. We're going to take a look at all of these, and then the stapes in the oval window. External ear, so auricle. So in acupuncture we have auricular acupuncture. It is needling different spots on the ear. So this whole thing, auricle or pinna, obviously this is the ear lobe or lobule. Right here is the helix. And the external acoustic meatus, or the EAM, the hole for the ear. And then coming into the middle ear area here, just this area in here. And we have our three smallest bones right here we'll take a look at. And then this is what we were just looking at, this area right here in the internal ear, or the labyrinth. You can see why it's called a labyrinth. This is the pharyngotympanic or auditory tube, or you might hear most people still calling it the eustachian tube. I know I do. This is of note when we are adjusting or massaging babies and children especially. So this is more vertical in adults. It is more horizontal in babies, and it's due to lack of cervical curve. And so this stagnation that occurs when this is horizontal is to blame for a lot of otitis media or middle ear infections. And then when we get the cervical curve into our neck from a lot of tummy time and stuff like that, this starts to go more vertical, and it'll drain into the nasopharynx or the back of the throat, and we won't get as many ear infections, and the kid grows out of it. So we can facilitate this drainage with manual therapy. There's that tube again right there. A little bit nicer of a picture of this middle inner ear structure here too. So we can see the oval window here deep to the stapes. We can see entrance to the mastoid antrum in the epitympanic recess, just this little hole right there. The malleus, also known as a hammer, like a mallet, right? Malleus. Incus, or an anvil, right? Looks kind of like an anvil. Stapes or stirrup. This one looks like a stirrup to me, like what you put your feet in when you're riding a horse. Makes sense. We call those the auditory ossicles. Note os is bone. Tympanic membrane or eardrum, tympany. Think the tympanic section of an orchestra. It's the drums, right? And then the round window right here. We can see the vestibular nerve going to all of the vestibular structures here. Cochlear for hearing, cochlea, like the conch shell. Right. And our tube again. And vestibule is here, and our semicircular canals. Inner ear, also referred to as the labyrinth, because it looks like a maze, as we just saw. It's located in the temporal bone behind the eye socket. There's two major divisions. We have a bony labyrinth and a membranous labyrinth. Bony labyrinth, system of tortuous, which means, think of it like an old country road, so windy. Tortuous channels and cavities that worm through the bone. Sounds kind of gross, worm through a bone. Bah. Divided into three regions: vestibule, semicircular canals, and cochlea. And it's filled with perilymph fluid, which is similar to cerebrospinal fluid. The membranous labyrinth is a series of membranous sacs and ducts contained in the bony labyrinth, and it's filled with a potassium-rich endolymph. Perilymph bone, membranous endolymph. Another picture here just to kind of think about it again after reading that, so you could see how it is tucked away in this temporal bone. All right. Now think about this when you are doing your cranial work. Cranial sacral as a massage therapist, or sacral occipital technique as a chiropractor, or any manual technique with subtle shifting of the cranial bones. What's going on with this apparatus here if it's tucked into this temporal bone area? Vestibule. It's a central egg-shaped cavity of bony labyrinth. So when you walk into a building, think about the vestibule that you're walking into. That entryway is called a vestibule as well. So the vestibule of the inner ear contains two membranous sacs, the saccule and the utricle. The saccule is continuous with the cochlear duct. The utricle is continuous with the semicircular canals. The sacs house equilibrium receptors, regions that respond to gravity and changes in the position of the head. So basically our saccule is really going to be for vertical. So think about going like up and down in an elevator. And then the utricle is going to be more associated with horizontal movement. So riding in a car, like car sickness, I would blame the utricle on that. When I lived on the 22nd floor of a high-rise building in Chicago, and then would go to work on the 17th floor of a high-rise, I was in an elevator a lot, multiple times a day. And if no one was around in the elevator with me, I would stop the elevator halfway through. So I would press like the 10th floor just to acclimate myself at first for maybe the first couple months that I was living in a high-rise and working in a high-rise, because without doing that, my saccule was not liking it and was making me car sick, just like if I were commuting on a bus. So saccule for elevator, utricle for car. Semicircular canals, 3 canals oriented in 3 planes of space, so anterior, lateral, and posterior. Anterior and posterior are at right angles to each other. The lateral canal is horizontal, so that's why it's called the horizontal canal sometimes. Membranous semicircular ducts line each canal and communicate with the utricle. The ampulla is an enlarged area of ducts of each canal that houses equilibrium receptor regions called the crista ampullaris. Now, these are receptors responding to angular rotational movements of the head. And another picture here, same one, just to kind of build on what we're learning. So we saw our semicircular ducts and the semicircular canals. Now we saw a little bit about the crista ampullaris and utricle and saccule here. Cochlea, small spiral-shaped conical bony chamber, size of a split pea. It extends from the vestibule, coils around a bony pillar. It contains the cochlear duct, which houses the spiral organ, used to be called the organ of Corti, and ends at the cochlear apex. The cavity of the cochlea is divided into 3 chambers: scala vestibule, scala media, scala tympani. Scala vestibule abuts the oval window, contains perilymph. Scala media, the middle one, with our cochlear duct, contains endolymph within. Scala tympani terminates at the round window and contains perilymph. So we've got 2 perilymphs and an endolymph. Scala tympani and vestibuli are continuous with each other at the helicotrema, or the apex. The vestibular membrane, or the roof of the cochlear duct that separates the scala media from the scala vestibuli. Stria vascularis is the external wall of the cochlear duct composed of mucosa that secretes this endolymph. And then that floor of the cochlear duct is composed of bony spiral lamina and the basilar membrane, which supports the spiral organ. The spiral organ contains cochlear hair cells, functionally arranged in one row of inner hair cells and then 3 rows of outer hair cells. Hair cells are sandwiched between the tectorial and basilar membranes. The cochlear branch of nerve 8, cranial nerve 8, runs from the spiral organ to the brain. Don't worry, I have pictures coming up. Here we go. So we can see this helicotrema at the apex, right in here. We can see the modiolus, this guy right in here, this area here. Cochlear nerve division of vestibular cochlear, so cochlear tells us it's the hearing part. We can see the spiral organ, or spiral ganglion. You can see the osseous spiral lamina, so bony part. Vestibular membrane, and the cochlear duct, the scala media, middle. And a nicer, bigger picture for you here. So let's start on the top left. Let's look at this vestibular membrane right here, okay? That membrane around it. And then let me erase this here. And then you can see the tectorial membrane. I'll go for green here. Okay, so follow it down and you can see this kind of wave-like structure here. There's another bigger picture here of this aspect as well. So we'll see that in a minute. Cochlear ducts, scala media, the middle guy. Okay. Scala vestibuli, this guy right here with perilymph. Scala tympani with perilymph. And then the spiral organ in here, we're going to see a bigger picture of that as well. See the basilar or the kind of basement membrane. And then check out the spiral ganglion here. So remember, ganglion is just where the cell bodies are. There's that bigger picture I was promising. So you can see that tectorial membrane, kind of this wave-like looking structure here. You can see these little hairs, little tiny hairs here, little hairs. We call them stereocilia. And then we could see these inner hair cells and the outer hair cells, inner, outer hair cells. These are supporting or stromal cells. And I'll switch to red here, fibers of the cochlear nerve. And then we can see these afferent nerve fibers of that cochlear nerve. And this basilar membrane here, basement membrane. Another cool picture here, we can see the hairs of the inner hair cells and the hairs of the outer hair cells. Kind of neat looking. So summary here for our internal ear. So the bony labyrinth of the semicircular canals, we've got semicircular ducts as the membranous part. Their function is for equilibrium and specifically rotational or angular acceleration, and their receptor region is the crista ampullaris. The bony labyrinth of the vestibule correlates to the membranous labyrinth of the utricle and the saccule, and this function is for equilibrium, head position relative to gravity, and linear acceleration, so elevator and car, think. And then the receptor region is going to be the macula. Cochlea, it's hearing. Okay, so membranous labyrinth, cochlear duct, scala media. Function is hearing, and the receptor is the spiral organ. The horizontal canal detects angular acceleration of the head when the head is turned. Okay, so we're going to see superior and posterior canals detect vertical head movements when the head is moved up or down. Nice little picture for you here. I have the citation of where I got this from as well. It's a paper. So LARP plain means left anterior, right posterior. Okay. RELP is right anterior goes with left posterior. And what that's talking about is this right here. Okay, so left anterior canal, right posterior canal. Okay. So this is how we know where we are in space without getting dizzy. So you can see why dizziness is such a common symptom, right? And what's going on with that? So any shift in the fluid, right? So maybe they're dehydrated and they don't have enough endolymph or perilymph, or maybe they are swollen and they have too much, right? They're not going to be able to properly know where they are in space. I think of it kind of like a level in construction where you have the air bubble in the water. Not exact here, but pretty darn similar. Now imagine that there's so much water in there that the air and pressure that air bubble can't move, and you can't figure out what the level is trying to do. So it stops the function of the level, so you don't know which way is up. So same kind of thing can happen here. Or if it's too loose, right, that's an issue as well. Cool picture here of our semicircular canal. So check out this website. It moves, so it really helps kind of drive this home. It's a little video, an educational tutorial here for understanding this. So what's going on with this guy down here? LARP, left anterior, right posterior being activated. And then we can see RELP over here, right anterior, left posterior being activated. So which way is that patient getting dizzy, right? So this is going to be some of the fundamentals for our Hallpikes and our Epley's maneuvers. There he is again. RELP and LARP, and then lateral. RELP, lateral, and LARP. Head rotation. So we've looked at this, so don't let it panic you too much. It's just kind of bringing it home for us here. So we see this head rotation here. Okay, so coming this way, there's the nose, here's the eyes, right? And so we could see lateral rectus, medial rectus muscle. Let's look at the left eye here first. So we could see cranial nerve 3. Now remember, this is bilateral. It would just be way too busy if it was labeled bilaterally. So this is bilateral and symmetrical. Okay, so we could see cranial nerve 3 in charge of medial rectus here. Okay. Everybody except for lateral rectus and superior oblique, every eye muscle. And then we can see the nucleus here for cranial nerve 3. And then this guy here, cranial nerve 6, coming along. And here's his nucleus. And note, this would be the midline. It's not labeled here. We're used to seeing it labeled, but that's okay. And then I'm going to switch colors here for our MLF, our medial longitudinal fasciculus, coming along here. You are probably hearing a lot of motorcycles and cars in the background. It is Memorial Day weekend, and I live on A1A in Daytona Beach, so it is what it is. I can't keep pausing it, otherwise we'll never get done. Okay, so that's what all that background noise is. So where are we? We've got our cranial nerve 6 coming along here. Cranial nerve 6's nucleus here, nucleus over here as well. Remember, these are bilateral. We have cranial nerve 3's nuclei here, and this one here for this guy here. And who's crossing the midline? MLF, medial longitudinal fasciculus. Okay. So then, what are we looking at here? We could see the vestibular nuclei here. Okay. Now, here's that horizontal semicircular canal. Okay. Semicircular canal fluid movement is going to give information into that vestibular nuclei. So we're getting information from our eyes and from our canals. And it's going to give information back and forth through this commissural neuron here to the other vestibular nuclei. It's getting information from here as well. So it's all connected. So if we see eye movement issues, we want to correct that. If we see balance issues, we want to correct that. How do we correct that? So balance issues, I work with eye movements. Eye movements are easy to do. So if they're having really bad vertigo and you can't move them around, and the Hallpikes, the Epleys, all those can create more issues sometimes than they're worth. Your patient might puke or go into some sort of autonomic reaction where their heart rate goes up or down and their breathing gets affected and their oxygen sats go down a little bit. It's too much. What are you going to do? I'm going to start with eye movements, and this is why. Seems too simple, but as you just saw, it's not simple, right? But the actual action is very simple. Left, right, up, down, and then turn the head. While they're seated, they can do this, or while they're laying down, right? Depending on what's going on with them, if seated or laying down is worse or better, do what's better first, right? And then train them in the position where they're strong at first, and then go into the positions that start to minorly stress them out and make them strong in that region. It's taken from this paper here, so ResearchGate and semicircular canals and eye movements. And I really like this paper, so check it out if this is of interest to you. It's of extreme interest to me. It's the basis of what we do as chiropractic neurologists, so it's interesting. So during superior vestibular neuritis, okay, so vestibular balance, neuritis, inflammation of that nerve, okay, so vestibular nerve is inflamed. Only the ISC of the affected side is still functioning. So during torsion of the head towards the affected side, the contralateral vertical semicircular canals stabilize the eyes in the vertical plane, but they do not move horizontally. So a horizontal catch-up or saccade is necessary to bring back the sight on the visual target. During torsion towards the healthy side, eyes move almost normally in the horizontal plane. A slight deficit of the VOR, vestibular ocular reflex, is due to the absence of inhibitory action of LSC of the affected side. But due to the isolated action of ISC, eyes move improperly downward so that an oblique, mostly vertical catch-up saccade is triggered. Activation of semicircular canals and eye movements during HIT or head impulse test in normal conditions and in superior vestibular neuritis is shown here. Okay, so in normal conditions, activation of both vertical semicircular canals stabilizes the eyes in the vertical plane. Only the action of the LSC moves the eyes, so no catch-up saccades are necessary to stare at the target. Vestibulo-ocular and optokinetic movements then are going to compensate for head movement. So as we see, one of the greatest threats to stability of images on the retina is the constant head movement that occurs as we walk, run, fly, swim, and all jawed vertebrates use essentially similar mechanisms to deal with this. Head movement not only stimulates these semicircular canals and otolith organs that we just saw, but also causes the image of the outside world to begin sweeping across the retina. Both sets of sensory signals are used to generate compensatory eye movements. So the VOR and OPKs work together. Let's talk a little bit more about these optokinetic eye movements and how it relates to functional neurology. The optokinetic tape is an essential part of the functional neurologist toolkit. It can be used to evaluate optokinetic nystagmus, which provides a window of assessment into the functionality of the frontal lobe, parietal lobe, cerebellum, and other brain regions involved in the generation and control of optokinetic eye movements. The optokinetic tape can be also used to rehabilitate functional deficits within these brain areas, which also makes it a powerful treatment modality. OPK nystagmus is made up of two eye movements. Smooth pursuits, which is initiated primarily by the parietal lobe, ipsilateral to the direction of the pursuit. Saccades, initiated primarily by the frontal lobe, contralateral to the direction of the saccade. The pursuit and the saccade should be equal in amplitude and opposite in direction. This information was taken by the website here, Neuroseminars, and you can check out that website and get some more information on that if you like. The picture that goes along with that is this diagram. It illustrates horizontal OPK nystagmus elicited by movement of the tape from a patient's left to right. A rightward pursuit initiated by the right parietal cortex is followed by a leftward saccade initiated by the right frontal lobe. The left cerebellum helps to control the accuracy of the leftward saccade. So you see this striped tape here. So what we do is we move the tape. So you can print this out. It's just stripes. So you can get creative with it. You can have an app on your iPad and have them watch it and then watch their eyes and see how the eyes are moving and in what direction. Diagram B shows the diagonal OPK nystagmus from up left to down right of the patient's perspective. The midline cerebellum has been shown to significantly contribute to diagonal movements, especially pursuits. A downright pursuit activates the right parietal lobe and the left cerebellum. It's followed by an up left saccade, which activates the right frontal lobe and left cerebellum. Diagram C describes different directions of OPK stimulation in relation to brain regions it activates. Direction-specific OPK stimulation can be used both to test and to rehab a particular side and region of the brain. So vertical OPKs, for example, are right off center to stimulate left frontal lobe and bilateral mesencephalon. What's the mesencephalon? Midbrain. Horizontal OPK, example would be rightward OPK stimulates the right parietal lobe, right frontal, and left cerebellum and bilateral pons. Diagonal OPK, right upwards, is going to be for right parietal lobe, right frontal lobe, and right cerebellum. Right down, right parietal, right frontal, left cerebellum. Left up, left parietal, left frontal, left cerebellum. Left down, left parietal, left frontal, right cerebellum. Now, do we have to memorize these? No. We can use this chart and help figure out what our patient has a problem with, what's deficient, and then use this chart and basically just highlight it for them and rewrite this for them and say this is what we're going to do. So we're going to do, the way I like to work is exercise all of it a little bit. All right, so do the full range of eye movements and then do 3 times as many of the deficit. Okay, so we want to strengthen the deficit first, but we still want to activate the other aspects. So other parts of this presentation have told you other people's opinions on, strengthen the weak side first and then balance it out later. I totally agree with that, but my way of doing that is 3 to 1. So whatever the deficit is, no matter what in their rehab, if it's their left leg or their right leg, or if it's their right parietal lobe versus their left, I'm going to still activate the pathways for everything, and then just do 3 times as many, or 3 to 1 rather, the deficit side. When testing optokinetic eye movements, the practitioner should observe for the speed of nystagmus, smoothness of the movement, whether the amplitude of the pursuits and saccades is equal or whether the eyes gradually drift to the right or the left, fatigability of the response, and if a deficit is found, other tests for the brain region in question should be performed to confirm or refute your diagnosis. Never rely on just one thing. We want to paint a whole picture. So it's not necessarily just 1 + 1 = 2. We want to get a whole understanding. For example, if the OPK saccade component appears to be deficient, testing volitional rather than reflexive saccade, so volitional just means voluntary. Okay? So testing volitional saccades along with other tests of frontal lobe function, such as anti-saccades and rapid repeated index finger to thumb opposition, will aid the diagnostic process. Cerebellar function should also be tested since the cerebellum helps to control the accuracy of saccades. If, on the other hand, the OPK pursuit component appears to be failing, testing different directions of pursuits, along with other tests of parietal lobe function, such as graphesthesia, stereognosis, sensory discrimination, and joint position sense, would be indicated. Let's put this into practice a little bit. So what would our instructions to the patient be? Optokinetic eye movements are reflexive in nature, so should be elicited by the patient simply by looking at the moving OPK tape. And there's an example of the OPK tape at the bottom there. So I put a YouTube link in there for you so you can practice it on yourself, and you also have that for your patient as well. So that one is to the right, and it'll move, and try it. It's kind of interesting. The initial instruction to the patient should therefore be look at the tape. Some patients, however, will fixate their vision straight ahead in response to this instruction and will thus suppress the OPK reflex. In this case, the patient should be instructed to watch each successive red square as it appears in front of them. Prescribing optokinetics as a home therapy. Optokinetic stimulation powerfully stimulates the brain and is therefore an invaluable therapeutic modality. Some patients, however, are not able to metabolize stimulation of such intensity very well, in which case you will see rapid fatigue of the OPK response, or the patient may feel sick or dizzy after OPK testing. When prescribing OPK stimulation as a home therapy, be sure to test what speed and duration of stimulation the patient can cope with, and then give about 2/3 of that to do at home. Another thing that I personally do is have them wear a pulse ox. So it's a quick, easy, cheap way to do biofeedback and check in on their oxygen. So if their oxygen starts to lower, anything under 96 and lower, I'm not a fan of. So other resources are going to tell you lower is okay. I don't agree. And then any change, significant change in heart rate. So anything 10 beats slower or 10 beats faster, and we're going to back off, let them recover, and then go back at it again. Let's talk about nystagmus here. It's a rapid, rhythmic, back and forth eye movement. It consists of rapid component, quick flick of the eyes in one direction, and a slow component or a slow drift in the opposite direction. We're going to name it for the rapid component. So we're going to look here at, we have a horizontal nystagmus, we have vestibular nystagmus, OPK nystagmus or optokinetics. Both of these are going to be physiological. We see rotation of the head activating the vestibular apparatus, which activates our VOR, our vestibular ocular reflex. When head rotation is greater than what can be compensated by our VOR, the eyes reset with this rapid movement in the same direction as rotation, and then compensatory movement of the VOR can happen. The rapid reset, followed by the slow movement mediated by the VOR, is called vestibular nystagmus. Another picture here for us. So I'll get my red marker here. Nystagmus, fast component and slow component. You can see the slow is in green and the fast is in pink. And then what's going on over here? He's rotating his head, so acceleration of the inner ear. And he's going this way here. Okay. Eye movement in the VOR. Okay. Slow. reset, fast. Okay, little flicks of the eye. We can train this. Okay, so I do this as part of my neurobalancing yoga classes. So we play around with balance positions and VOR activities. Caloric testing. So remember our mnemonic cows, the cold opposite, warm same. So cold water caloric versus hot water or warm water, you don't want to burn them. Warm water caloric testing. So what's going on here? We see this right ear being irrigated with cold water here. Okay. Gravity vector. Okay. Movement of the endolymph from a more dense, cooler to a less dense or warmer area would happen here. Okay, so we could see this ice cold water coming in, and then that's going to cause a change here of that movement of that endolymph. Okay. Down here, our chart, irrigation right ear. We would see, this is for cold water, we would see a clockwise movement. Type of head movement that it's stimulating or simulating is left. Slow eye movement, VOR right. Fast eye movement or direction of nystagmus, left. Cold, warm. Okay, right ear warm, counterclockwise, endolymph movement simulates right head movement, slow, left, fast, right. Left ear movement of the endolymph would be counterclockwise for cold, clockwise for warm. Okay, so you could see here that it's simulating for cold, left ear cold would be simulating right head movement. Okay, so do you have to memorize these? Absolutely not. Is this chart available? Yes. Are you going to be doing these tests? Maybe very few of you would, right? It's a pretty specialized test, not done by many practitioners out there. The idea is that this exists, and we know that this warm and this cold is going to simulate different head movements, and it's a test that's done a lot of times by chiropractic neurologists. So it's available for you, but you can also just move their head and see the eye movements as well. Vertical gaze center, so our midbrain reticular formation in the pretectal area, so the area just rostral to superior colliculus. So tectum is that superior inferior colliculus, remember? Anterior portion mediates downward gaze, posterior portion mediates upward gaze. So I remember this one pretty easy. Up, U, P, up, posterior. Done, easy, right? Input, frontal eye fields and visual association areas via superior colliculus. So look in here, we see our vertical gaze center, midbrain reticular formation, pretectal area, and what are we looking at here? Cranial nerve 4, okay. SO4, superior oblique. And then we could see nucleus of cranial nerve 3. Disconjugate gaze. So conjugate gaze would be the eyes are moving appropriately together, yoked together. Disconjugate, not. Okay, so information about an object near or far relates to both occipital lobes. So Brodmann 17, remember the visual aspect. Okay, so occipital lobe via the two lateral nuclei of the thalamus. In the occipital lobes, the information is integrated, and the decision to converge for near objects or diverge for far objects is made, and it's relayed to these vergence center, vergence, convergence, divergence. Okay? In the rostral midbrain, near cranial nerve 3 nucleus, which makes sense because that's who's going to be doing the majority of the work. Okay? Cranial nerve 3 is activated bilaterally, innervates both medial rectus muscles for convergence, and then cranial nerve 6 is activated bilaterally and innervates lateral rectus, LR6, for divergence. Okay. And here's our picture for those of us that like pictures. Number 1, eyes converge on a near object to focus in. So follow your finger, bring it in. So arms length out, one finger up, bring it in towards your nose, convergence. Okay, follow it further out, divergence. So we can see medial rectus. If it's medial rectus, what cranial nerve nuclei is this? Yes, cranial nerve 3 nucleus. Good. And then cranial nerve 6. Right, chit-chatting together here through that vergence center there. So convergence, both eyes adduct. Okay, so convergence, that's both eyes are adducting. So when we look at accommodation, we're looking at the focus that's going to happen here. So convergence, both eyes adduct. We see the refractive power of the lens increasing, the curvature of the lens. So we need to change the shape of the lens. It's focusing the camera basically here. Okay? Pupils must constrict to increase the depth of field. These 3 components of accommodation response are termed the near triad. So 3 things. 3 things. So adduction of the eyes, so bringing the eyes in, so following your finger in. A change of the lens shape to change the focus, and then the pupil constriction as well. Near triad. Accommodation is coordinated through the supraocular motor area, SOA, in the rostral midbrain by sending excitatory projections. Right? And it's going to give input into that visual cortex or Brodmann's 17 area. Basal nuclei and cerebellum participate in eye movement control. So one of the multiple parallel loops through which the basal nuclei affect cortical outputs, we looked at this in a different chapter, chapter 19, directly influences the production of saccades and pursuits. Pursuits, smooth pursuits, we're watching something slow. Saccades is that quick catch-up. The input side of the loop originates in the frontal and supplementary eye fields and the cortical areas and projects to the body of the caudate nucleus. The output side involves modulation of the frontal and supplementary eye fields in the superior colliculus, so that visual reflex, remember, by varying levels of inhibition emerging from substantia nigra, or the reticular part of the substantia nigra. Consistent with this pattern of connections, patients with basal nuclei disorders like Parkinsonism, Huntington's disease, exhibit a variety of eye movement abnormalities, reminiscent of the abnormalities of other movements. These include involuntary saccades during attempted steady gaze, small saccades, diminished numbers of spontaneous saccades, and slowed pursuit movements. So eye training, we do eye movement training for every neuro issue. So find me a neuro issue that isn't going to have abnormal eye movements and won't be helped in some way of doing eye movements. Eye movements are easy, they're cheap, free to do at home. It's a great thing to add to your practice. Some deficits that we might see. So this gentleman is demonstrating a lesion of the MLF, so medial longitudinal fasciculus. So medial longitudinal fasciculus is highly myelinated. It's a common area that we'll see some sort of dysfunction with our multiple sclerosis patients. So this demyelination can cause this internuclear ophthalmoplegia, INO for short. Internuclear, between the nuclei, right? That's what that MLF does. It crosses over the midline and yokes the nuclei together, so we call it internuclei. Internuclear ophthalmoplegia, ophthalmo, eye, plesia, paralysis here. Right? So eye fails to adduct on the affected side. Nystagmus of the abducting eye can be seen, and the causes can be from infarct, so that would be stroke, demyelination, so MS for central nervous system is what we're going to think of the most here, syringobulbia, drug toxicities. Okay, so if I see this, my money is on MS though. That's how much more common that is. Let's look here on the cerebral aqueduct and inflammation, where we're looking at, look at the picture on the right for the yellow here, that ocular motor nucleus and the trochlear nucleus. Okay. You can see abducens nucleus here as well. Okay, so we have our superior colliculus, inferior colliculus, so we know we're in our midbrain. We can see the bump of the pons here. So what happens if we have some sort of increased inflammation and we have specifically like a concussion or even just an inflammatory condition can cause slight neurological deficits because we get systemic inflammation, including here at the ventricular system. So the idea here is that this, if you look to the picture on the left, a little red marker in the middle in that cerebral aqueduct, is very thin. So when we do see an increase in cerebral spinal fluid or this increase in inflammatory response here, if we are here in the lateral ventricles, we have a little bit more space to it can push out just a little bit and we might not feel any effects. We might not see any deficits right away, right? Or anywhere else in the brain. But the idea that this is so thin that if we start to see any pressure this way, one way, or the other, we're going to start to see deficits, even in the most minor of inflammatory responses here. So if we look over to the right where it is, that same area is expanded here, I'll erase these guys here again. What is right here, right, looking on the left, what is right here is this right here. Look at how close those nuclei are to that cerebral aqueduct, right? So if you get a little bit of pressure, a little bit of swelling in this aqueduct, we're going to see ocular motor nucleus affected, which is going to affect the ocular motor nerve. We're going to see trochlear nucleus affected, which would affect the trochlear nerve. So we're going to see eye movements affected at the slightest bit of inflammation is the take home for this. So super important to be doing eye movement tests with our patients. And no matter what modality we're working on, we want to check brain inflammation and either rule that out or rule that in as part of our treatment options, no matter what other organ system is of complaint or no matter what their chief symptom is. We need the brain and the spinal cord to be functioning on all cylinders here first, right? Brain, central nervous system, brain and spinal cord control every single aspect of our body. So let's look here at the effects of a normal versus a Chiari malformation or cerebellar tonsillar ectopia. So looking here at the top left, I call this one normal. Let's look at my red marker. Here is the foramen magnum and our cerebellum, including the tonsils, is above it. That's great. Same thing happening here with flexion. There's some stuff going on in the cord here that, might need to be addressed, but we see the cerebellar tonsils are up a bit higher in flexion. Note the series at the bottom. So we see this red line. I didn't draw that red line on there. It was already drawn. If I were to draw it on the two right pictures there, I probably would have drawn that right side up just a touch higher, but it's okay. It still illustrates the point for us. So this right here, cerebellar tonsil. Okay? Here, cerebellar tonsil. Here, cerebellar tonsil. We want that cerebellar tonsil to be above this red line. Okay? It is not. I'm going to erase my marks here so you can see it without my marks. I just wanted to point out where to be looking here in our discussion. So what's going on with flexion here? Think of text neck, right? So looking down at our phones or book or whatever we do all day with the computers, right? And they're going to be all right here. But when they go back to more of a neutral spine, we see a little bit of the cerebellar tonsil herniating through the foramen magnum. And then when they go into extension, it's even more so. Okay, so the idea of the differences between flexion, neutral, and extension and the pressure that puts on the neck here. Okay, so we don't want to get used to that flexion position there. We want to slowly train into a better cervical curve in order to help with this. So the idea of why do I have it in this PowerPoint here, think about that inflammation of the cerebral aqueduct that I was just talking about. So do we think that there would be good cerebral spinal fluid flow through that foramen magnum area here, or do we think that might be impeded a little bit and then cause a little bit of a backup in that cerebral aqueduct as well, and then into cranial nerve 3 nucleus and cranial nerve 3, and then eye movements. So with your CTE or your Arnold-Chiari patients, CTE being cerebellar tonsillar ectopia here, your other CTE patients, you're for sure doing eye movements as well. But for any of these neuro issues, let's check out eye movements. And that's why, right? So looking at the structure dictates function, and we can bet that that's going to be a problem. So we want to do some extension, cervical curve exercises, and eye exercises for better balance, because we see how the eyes are related to the vestibular system and the canals. Normal versus aqueduct stenosis. So we're looking here on the left again. You can see my little red marker here. That is the cerebral aqueduct. Okay. So a little orientation here. Frontal, okay, frontal lobe here. Corpus callosum here. Cerebellum, this guy back here. Okay, pons is here. So medulla is below. Midbrain is above. And we can see superior, inferior colliculi, and the cerebral aqueduct, fourth ventricle. Okay. So looking here at the amount of fluid in this kind of lateral ventricle area here, now this one on the right makes a big difference. That's a massive amount of fluid backed up from this yellow area. I can't erase that, that came with the picture. So that is from a stenotic or narrowed cerebral aqueduct that's causing that backup of fluid. So this is an extreme case, right? But it helps us to learn. Look at this poor little fourth ventricle and how much smaller that is. And then the area of cerebral spinal fluid on the left, underneath that cerebellum, we've got no space here. That's all cerebellar tonsil. And you can see where it's all just inflamed. It's kind of blurry, where we see kind of crisper structures on the left, and then it's all just kind of blurry and inflamed on the right. So this slide, I want to kind of pull it all back together, right? So we learned where our structures are, what the functions are, and then we started to see just a couple of images on where the structures are and what could go wrong, and then the idea of where this is, right? So we're looking at the frontal cortex here in this picture. We can see the frontal eye field here, Brodmann's 8, right? And then we've got our midbrain area here, and we've got our pons area here. Medulla would be down here. Okay, so cranial nerves 3 and 4 in the midbrain, 5, 6, 7, 8 hanging out in the pons. And then where's our MLF? It's right here, that green line crossing over the midline. Okay, we can see this PPRF, paramedian pontine reticular formation, at this area. So correlating this picture to what we just saw in our imaging and starting to see, paint the picture of what's going on. So we know the structures, we know the functions, we could see what's happening in the MRI and the inflammatory response, and then start to correlate it to the subtle things that we find on exam. So eye movements, hopefully you can see how important examining subtle eye movement changes or drastic eye movement changes are, and then the importance for doing eye movements as therapy and how it correlates to the whole system, and now how we saw how it correlates to the balance systems in the inner ear. Good job, you made it through another lesson. So check in on your webpage for your resources and for the quizzes, and I will see you for the next lesson. Thank you.